स्टार्ट करें भाई। Hello, everybody. Good afternoon. I'm Dr.Azmi Mohsin, Faculty of Anatomy at Nextillo. Very thankful to our director, Dr. Sunil Sharma sir, and the co-founders of the Nextillo team for providing us this platform to share our knowledge. This is an integrated session with anatomy and ENT. So we have decided to teach you all this topic, facial nerve. So I'll be covering here the facial nerve, its functional components, and the relevant anatomy. And then Dr. Pranshu will not, after that, will be teaching you about the clinical points regarding the facial nerve. Okay, so let's begin with this. So you know that the functional components of the facial nerve are special visceral efferent. That's the most important component. This is also called as a brachial efferent, right? It starts from this motor nucleus of the facial nerve. Then it innervates the muscles derived from the second brachial arch, including the muscles of the facial expression, then posterior digastric, stylohyoid, then posterior auricularis, occipitalis, etc. Then general visceral efferent, this provides, this is a motor, the parasympathetic outflow, right? It innervates the smooth muscles regarding, the glands, the secretion from the lacrimal glands, then submandibular, sublingual salivary gland, etc. General visceral afferent will bring in general sensations of touch, pressure, temperature, vibration from these areas like soft palate, hard palate, pharynx, as well as from the glands. Then special visceral afferent actually is going to bring in sensations from the glands like lacrimal and submandibular salivary glands. And general somatic afferent is going to bring in the general sensations, the exteroceptive sensations from around the pinna. Okay, let's begin with this now. So the remainder of this tutorial focuses on the functional components contained within the facial nerve, and these are the branches of the facial nerve. So like, first, second, and third you're seeing is greater superficial petrosal nerve, stapedial nerve, and chora tympani nerve. Now, these three are the branches given out of the facial nerve within the petrous temporal bone. So these are the intracranial branches. Before the facial nerve emerges out from the stylomastoid foramen, it is already given these three branches. Now, greater superficial petrosal nerve, general visceral afferent, it's bringing in general sensations from the hard palate, soft palate, and pharynx. And general visceral efferent will provide, parasympathetic fibers to the leg primal gland. Special visceral afferent is going to bring in, proprioceptive sensations as well as the, sensations from this lacrimal gland. Stapedial nerve is a motor nerve which will innervate stapedius muscle, which help in contracting stapedius and thereby reducing or dampening the vibrations of the stapes. Chora tympani nerve, it has these two components, general visceral efferent. This, is the parasympathetic outflow, and at the same time it will bring in special visceral afferent sensations, right, from the from the tongue, the anterior 2/3 of the tongue, except the circumvallate papillae. Then posterior auricular nerve, this innervates the muscles around the pinna, especially the posterior auricularis, right? So this will bring in general, sensations. This will, of course, will provide special visceral efferent because the muscle is derived from the branchial arch. As well, it will bring in general sensations from around the external auditory meatus. Then facial nerve, the terminal branch, remember, which perforates this parotid gland and divides into its 5 terminal branches, that is going to innervate the muscles of the facial expression and help in contracting and bringing out facial expressions. So there, the fibers running are the special visceral efferent, the branchial efferent fibers. The anatomy of facial nerve can be described in a single slide here. So focus on the facial nerve exits the posterior cranial fossa at the interacoustic meatus, remember, along with the vestibulocochlear nerve and its sensory division, that's the nervus intermedius. Within the interacoustic meatus, the facial nerve enters the facial canal. The first branch of the facial nerve, the greater superficial petrosal nerve, branch of the geniculate ganglion. Remember, it's the sensory ganglion of the facial nerve. So from there, it's the first branch that's given out by facial nerve is the greater superficial petrosal nerve within the genu of the facial canal and enters the middle cranial fossa by way of the hiatus of the cranial nerve for the greater superficial petrosal nerve, right? So it descends down and reaches into this, foramen lacerum, where it receives a deep petrosal nerve, and together there's a nerve called Vedian nerve or nerve pterygoid canal, and that goes further, that will be discussed later on. Right now, just focus upon the functional components. The second branch of the facial nerve, the stapedial nerve, branches from the descending portion of the facial nerve at the level of the pyramid and enters in the middle ear to innervate this muscle stapedius. The third branch of the facial nerve, the chora tympani branch, it branches from the descending portion of the facial nerve and enters the middle ear. Within the middle ear, the chora tympani nerve crosses the medial surface of the tympanic membrane. It then passes through the petrotympanic fissure to enter into the infratemporal fossa, where it will join the lingual nerve to innervate the, bring in taste sensations from the anterior 2/3 of the tongue, as well as the special visceral, visceral afferent sensations. That's the taste sensation. The descending portion of the facial nerve continues into the parotid region by way of its stylomastoid foramen. That was just a brief outlay, and here you see is a diagram because it's an animation thing, so I have to focus upon here fast. So remember now what you are seeing here. This is the nucleus of Tractus solitarius. This is the brain stem portion, the lower pons, upper portion of the medulla, where you find is this nucleus of Tractus solitarius, which which receives general visceral and special visceral afferent sensations. The special visceral afferent sensations are brought in into the upper part of this nucleus, and general visceral afferent sensations are brought in into the lower part of this nucleus. Here you're seeing is the spinal nucleus of trigeminal. This also has a role because the general somatic afferent sensations are brought into this nucleus. Then you're seeing is this blue color nucleus, that is superior salivatory and lacrimatory nucleus. That is special, that this nucleus is of general visceral efferent, the parasympathetic outflow. And here is the main nucleus, the motor nucleus of the facial nerve, which is special visceral efferent, which branchial efferent, which innervates the muscles of the facial nerve. So you have got the idea about all these nuclei, the 4 nuclei related to the facial nerve in the brainstem. The next thing is there, I mean, the color coding of these different functional components have been given different colors. So you can see the green one is from arising from motor nucleus. Then this pink color one is the general visceral afferent, and the brown color one is the special visceral afferent. Light blue is for general visceral efferent, right? For the parasympathetic outflow. Then, this facial nerve enters, this is the internal acoustic meatus, right? So from here, this facial nerve enters along with the 2 nerves, down below is the vestibulocochlear along with, and this facial nerve actually, when facial nerve emerges out of the pontomedullary junction, laterally from the junction, just medial to the vestibulocochlear nerve, then it ascends upward forwards over this, clivus, reaches to the internal acoustic meatus. Then within the intercostic meatus, there's an artery, labyrinthine artery also, which perfuses the areas here. Then this is the course of the facial canal in the petrous bone. So it ascends upwards, outwards, over to this vestibule of the internal ear. Then it gives a bend. This is a sharp bend, and it's called the genu, right? And then it has a smooth curve, descending portion of the facial canal, and then facial canal, and this all is curving around to the promontory of the middle ear cavity. On the middle side of the middle wall of the middle ear, there's a promontory. It curves around like this, and then emerges out down below through this stylomastoid foramen. So that's what the course. Now see upon the branches here. The first branch, as I told you, was this the greater superficial petrosal nerve, right? So this greater, there's a tegment tympani, the anterior wall of the, petrous temporal bone, which forms the roof of the middle ear. So through perforating through this hiatus for the greater petrosal nerve, it emerges, descends downwards and medially toward this foramen of lacerum. So when it reaches into the foramen of lacerum, it receives a deep petrosal nerve, right? That's a sympathetic fibers from the internal around to the internal carotid artery. Together, this is called the nerve, the pterygoid canal, the Weden nerve. This is going to relay this ganglion, parasympathetic ganglion is suspended through this maxillary nerve. And from then, through this zygomatic nerve, it will, through this greater and lesser palatine nerves, it will innervate the palate and pharynx. And through the, zygomatico-temporal, perforating the little wall of the orbit, then joining the lingual lacrimal nerve, will innervate the lacrimal gland. Then is a stapedius given out at the promontory. This is the second nerve, nerve to stapedius, which will innervate this muscle stapedius. And then down below is another nerve. This is chora tympani. This will emerge out and will reach the middle ear cavity, running between malleus and incus, just medial to the tympanic membrane. It will emerge out of the petrotympanic fissure. Then it will run medial. Remember, it will run medial to the styloid process. There's a nerve which runs lateral to the styloid process, and that's the facial nerve, right? Then it joins the lingual nerve and will innervate the taste receptors in the anterior 2/3 of the tongue, except the circumvallate papillae. Then after emerging of the stylomastoid foramen, this nerve gives these branches. Posteriorly, it gives this branch to the posterior auricular nerve. Okay. Then it also gives a branch to the stylohyoid and the posterior belly of the digastric, and the posteromedial surface of the parotid gland, and will terminally divide, above and below to the parotid duct to give out these branches: temporal, zygomatic, buccal, marginal, mandibular, and cervical, to innervate the muscles of the facial expression. So all the muscles that facial nerve innervates is the muscles derived from the second branchial arch. And remember, it's a post-traumatic nerve to the second branchial arch. Okay. So here you have seen that this is the facial nerve, where it exists, the posterior canal fossa at the internal acoustic meatus. Just follow the animation. Then you are seeing is within the internal acoustic meatus, the facial nerve enters the facial canal. there you find is there's the first branch of the facial nerve, the greater superficial petrosal nerve. It branches from the geniculate region within the genu of the facial canal and enters the middle cranial fossa by way of hiatus for the canal for the greater petrosal. And by the way, you're seeing here, there are cytons here, the nerve bodies. That means these are the first order sensory neurons with the cytons here, and that forms this ganglion. The geniculate ganglion is homologous to the Gasserian ganglion of the trigeminal. It is homologous to the dorsal root ganglion of the spinal nerves. Don't forget this. Okay. Then you are seeing is this, the second branch of the facial nerve, the stapedial branch, branches from the descending portion of the facial nerve and enters the middle ear. Then you are seeing is this nerve, the third branch of the facial nerve, the quadrant tympani nerve, branches from the descending portion of the facial nerve and enters the middle ear. Surface of the tympanic membrane, it then passes to the petrotympanic fissure to enter into the infratemporal fossa. Here you see is the descending portion of the facial nerve exits the facial canal at the stylomastoid foramen and continues into the parotid region. I have taught you about all the branches emerging from the facial nerve and its course within the cranium itself. Now you are seeing is the functional components. You should know about each of these functional components. Special visceral efferent. Remember, I taught you about this. This is an efferent to the muscles derived from the second branchial arch. General visceral afferent, right? It brings in pain, general sensation, sensory sensations of touch, pain, temperatures, right? Then special visceral afferent. A special visceral afferent is that which brings in taste sensation. Then general visceral efferent is an autonomic innervation, right? Parasympathetic outflow to the mucosal, lacrimal, and salivary glands. Then you are seeing is general somatic afferent. This brings exteroceptive sensations, right? Sensations of touch, pain, temperature from in and around the external auditory meatus, and maybe not directly or maybe through a communicating branch from the vagus. That's called Arnold's nerve. Auricular branch of vagus is called Arnold's nerve. Now here you're seeing is special visceral efferent of the facial nerve. We talk about this, right? The next 11 slides demonstration to the muscles derived from the second brachial arch. Keep a focus upon this. We're going to see the animation later on. So sickles, inserts on stapedius of the middle ear. Then posterior auricular muscle, that's posterior muscle, it elevates okay. So posterior is the digastric. It helps to elevate the hyoid bone as well as it depresses the mandible. Then muscles of the facial expression, they help in blinking, smiling, frowning, facial movements. So each of these movements you will find here. Now look here, we will talk about this function of stapedius. See here in the animation, this is function called special visceral efferent, right? How is this muscle going to interact? When there is a music outside, so music enters the ear and will stimulate the cochlear nerve, and through the cochlear nerve there will be communication to this motor nucleus of facial nerve, special visceral efferent nucleus. So from here you see that the green color fibers that will show you the animation how the stimulus reaches to the stapedius. So you see that this is the music reaching here to the ear, and then how this is stimulated, this motor nucleus of the facial nerve, and that's how the impulses travel up along to this fibers of special visceral efferent through the stapedial nerve. It will contract the stapedius and will prevent, dampen the ossicles, right? So if there is paralysis of stapedius, that will lead to hyperacusis. Now you're seeing is this posterior auricular nerve, which innervates the posterior auricular muscles and helps in pulling the pinna posteriorly. Right, so there's a stimulation of this motor nerve nucleus, and there the fibers you're seeing, they are running down along the course of this nerve, and through this posterior auricular nerve, it will reach to contract this muscle, posterior auricular muscle, and will help in retracting the pinna. Then you see the function of stylohyoid muscle. That also is a special visceral efferent function derived. This muscle also is derived from second branchial arch. You see the animation down here, and this will be through this branch, nerve to stylohyoid. This will contract and will help in elevating the hyoid. Okay. Then you see here the posterior belly of the digastric muscle elevates the hyoid. So you see that this muscle being innervated by this nerve. So this is the course of the impulse being traveling through this branch. This will innervate the posterior belly of the digastric, which will help in elevating the hyoid. Okay. So the next 6 slides demonstrate special visceral innervation to the muscles of the facial expression. So what will you find here? The temporal branch will reach to the through the zygomatic branch. With the zygomatic branch will innervate the orbicularis oculi, and that muscle helps you closing the eyelids. Zygomatic branch with buccal branch innervates the zygomaticus muscle, major muscle, which helps you in smiling. Then there's a buccal branch which innervates the buccinator, which tenses the cheeks and pushes the bolus, into the vestibule, and pushes the food between the teeth. So that's the function of buccinator. Now mandibular branch will innervate and depresses the anguli oris muscle and will show this expression of frowning or like grief or sadness. Cervical branch innervates the platysma and lowers the mandible as well as tenses the skin of the anterior surface of the neck. These are the key innervations to the muscles of the facial expression. However, each nerve branch innervates multiple muscles and each muscle receives multiple nerve branches, right? Okay, now here we're going to see is the temporal and zygomatic branches, right? These are the two branches here of the facial nerve, which provides special visceral efferent nerve fibers that innervate the ipsilateral, right? We're talking is about the ipsilateral orbicularis oculi in this nerve. So we're not talking right here about the upper motor neurons. It's all about the lower motor neurons. So they're going to innervate the muscles of the ipsilateral side. So the muscle responsible for closing the eyelid is orbicularis oculi. Now look here at this stimulus, how it's going to innervate this muscle. This is the stimulus arising from the motor nerve nucleus, and it will travel along the course of this nerve and through this terminal portion to the temporal and zygomatic branches, right? It will go and help to close the eyelids. Got it? Okay. So contraction of orbicularis oculi causes the closing of the eyelids. Then think about zygomaticus major, right? So this will help in smiling. You can again see the stimulus arising here in the motor, special visceral efferent nucleus, the fibers running. Then this will pass out again through this zygomatic branch and will contract this muscle, zygomaticus major, and this will help you smile. Then you're looking here is this muscle buccinator, the buccal branch of the facial nerve, which innervates the buccinator muscle, the muscle responsible for holding the cheek against the teeth, thus pushing the food for chewing, right? If you're taking a bite, so this bite should come between the teeth, and that's the purpose of buccinator, to push it between the teeth, right? So see here on the stimulus here, sorry, from the special visceral efferent nucleus, the stimulus arises and it travels along the course of the facial nerve. Then through the buccal branch, you can see here to the buccal branch, it will innervate the buccinator muscle. And this muscle, when it will contract, it will push the bolus between the teeth, right? So it's an accessory muscle of mastication. Don't forget that buccinator is an accessory muscle of mastication. Now down below you find the mandibular and buccal branches of the facial nerve innervate the ipsilateral depressors anguli oris muscle, a muscle responsible for expression of grief. So you here again start looking here with this animation thing. This stimulus arises here in this motor nucleus of the facial nerve. The stimulus running around, course of the facial nerve, reaching and contracting this muscle, depressor anguli oris, and will help you tilt the angle of the mouth downwards, which will provide an expression of grief. Then you're seeing is the cervical branch of the facial nerve, which innervates the platysma muscle, a muscle partly responsible for depressing the mandible, right? So here you're seeing is this new, stimulus arising in this motor nucleus. This stimulus will run along to this course of the facial nerve. Then through the cervical branch, it will reach to platysma, right? And will help in depressing of the mandible. Then another action of this platysma is called the shaping muscle. So this muscle is responsible for tightening the skin of the anterior surface of the neck. Again, see the animation here from arising from this motor nucleus. Now this will help to stretch out this muscle and thereby clearing the folds there in the front of the neck. It smoothens this. And summary of this special visceral efferent function, you can see here, it's the summary. So one by one you find is the stimulus reaching, and I've taught you this was the action for stapedius. This is the stimulus reaching to the terminal branches of the facial nerve for the contraction of muscles of the facial expression. Then another fibers reaching down to the stylohyoid and posterior belly of digastric. They will elevate the hyoid bone. All these stimulus are reaching to the muscles derived from the second branchial arch, and this will innervate the posterior auricular muscles, retracting the pinna. Okay, now the next functional component is general visceral afferent component of the facial nerve. So the next slide demonstrates the general sensations. So light touch, temperature, and pain sensations from the soft palate via the greater superficial petrosal nerve will be demonstrated here. You're seeing here is the soft palate, right? And we're going to see how now this will be an afferent thing, right? The stimulus will reach here, and remember special visceral, general visceral afferent fibers, the sensations, see the color coding, it will reach down into the lower portion of this nucleus tractus solitarius. So here you're seeing is the light touch sensation of the soft palate. Then the ice cream reaching down here. So there's a temperature sensation reaching to the soft palate. The syringe reaching to the soft palate is showing the sensation of pain. That's how the stimulus has arisen. Now they see the stimulus actually through this course of facial nerve will reach down here into the lower portion of the nucleus tractus solitarius through the greater palatine nerves. Okay, then see the summary for this. This is how the sensations started. And this is how this pattern of impulse reaching down here to the lower portion of nucleus tractus solitarius. Now you see about this special visceral afferent component of the facial nerve, right? That is for the taste sensation. So taste from the hard and soft palate via the greater superficial petrosal nerve, and taste from the anterior 2/3 of the tongue via the chorda tympani nerve, except the sensations from the circumvallate, because that's being carried by glossopharyngeal nerve. So here you're seeing is this sweetened coffee being received. Now the sweetened coffee, what does it do? Look here. When the sweetened coffee reaches down here, it will stimulate the taste sensations from the hard and the soft palate. And these taste sensations will be carried to the great palatine nerves and then reaching down here to this, the entire course I've already taught you, to the upper portion of this nucleus tractus solitarius. Now see the sensations of sweetness on the anterior two-thirds of the tongue. This is how the anterior two-thirds of the tongue is being stimulated. These fibers of special visceral afferent sensations via chorda tympani will be now reaching to the upper half of the nucleus tractus solitarius. Now this will be a summary of special visceral. You know, the taste is being carried from two nerves. That one is this greater superficial petrosal nerve from the hard palate and the soft palate. Then the sensations from the anterior two-thirds of the tongue are being carried through this chorda tympani. See the course. This will also relay here into the upper portion of this nucleus tractus solitarius. Now the next component is general visceral efferent component of the facial nerve. The via the pterygopalatine ganglion. You know, this is about talking about the parasympathetic outflow to the smooth muscles of the glands, and via to the submandibular ganglion, it will provide special. You know, this will innervate the the two glands, the submandibular and lingual salivary gland, and this will innervate the lacrimal gland and the mucosal glands of the nose, pharynx, and the palate. So via the pterygopalatine ganglions, general visceral efferent now fibers will reach to the lacrimal gland for tearing and mucus secretions from the nasal cavity and mucus secretions from the oral cavity. Via innervation of the now look here, the next one is through the submandibular ganglion, it will innervate the salivation of oral cavity. So here you're going to see about how this lacrimation thing, tearing thing will happen, and this stimulus to this will arise from this nucleus, lacrimatory nucleus, right? Now stimulus is here. So how will this stimulus reach to this lacrimal gland? You can see I have told you the course. This is the stimulus. It will run along to this facial nerve and wire to this greater superficial petrosal nerve, maxillary nerve, zygomaticotemporal nerve, then reaching to lacrimal nerve. After being relayed here in the pterygopalatine ganglion, this will, this is the course here, and it will innervate the lacrimal gland. It will cause tearing. Okay. Another thing, it will also cause secretions from the nasal cavity. Okay. Then you are seeing here is the other function of this. This will also cause secretions from mucosal secretions from the hard and the soft palate. Okay. Then think about how these secretions from the submandibular and sublingual salivary glands are being controlled. Now this will be through the chorda tympani branch, and the functional component is general visceral efferent, the parasympathetic outflow. Again, from the superior salivatory nucleus, the fibers you're seeing are coursing along the facial nerve, and through the chorda tympani, it will relay into submandibular salivary, submandibular ganglion, and will be distributed to these glands to cause salivation. Both from submandibular as well as from sublingual salivary glands. It will cause salivation. Now the summary here of general visceral efferent, I told you the two nerves, greater superficial petrosal nerve will innervate the lacrimal gland, the mucosal glands from the nasal cavity, from oral cavity, pharynx, soft palate. Now these impulses are reaching through this chorda tympani and relaying here in the submandibular ganglion, and from there the fibers will reach to the two glands, submandibular and sublingual salivary glands. general somatic component of the facial. Now, this is general somatic, right? So it's bringing sensation on the exteroceptive receptors, right? Touch, print, temperature from outside. So touch, temperature, and pain sensations from part of the external acoustic meatus via posterior auricular nerve, maybe directly, and as I told you, maybe via communicating branch from the facial nerve, that's the Arnold's nerve. See here now, this is like the external auditory meatus is going to be stimulated, and how these impulses will be reaching to this, this spinal nucleus of trigeminal, right? So this is through the posterior auricular nerve. So this is how a cotton swab being inserted here in the external auditory meatus, right? And the general sensations being carried, now you see is being, these general sensations are being carried through this posterior auricular nerve and will be reaching down here into the spinal nucleus of trigeminal. Actually, we call it as auricular branch of facial nerve also, which reaches the middle ear. Now, the summary is nothing. There's only one branch which is carrying these fibers, the black color fibers, and they're being relaying here into the spinal nucleus of trigeminal. Okay. The summary of functional components, each of the 5 functional components of the facial nerve, you know that special visceral, general visceral, special visceral afferent, general visceral efferent, general somatic afferent have a unique function. I have demonstrated all these functions. Knowledge of these functional components can be applied to the clinical observations to aid in localizing lesions of the nerve branches at the anatomical landmarks. The following slides are going to now provide examples of how lesions at different locations can affect functions. Now look here, this is a question for you people, and I believe if you are there on the chat box, you can share your answers here. Okay. So here you're seeing is the question here. One effect you're seeing, I have this is the same slide on which I have taught you right now. So this is the side of lesion. Focus upon this side. One effect of a lesion here between the branching of stapedial nerve and the branching of chorda tympani nerve would be what it will lead to. You see the lesion here, right? Between the branching of stapedial and chorda tympani, this will lead to paralysis of facial muscles. Sure. Okay. Decreased sensation of the soft palate. They're already being carried, right? Then increased sensitivity to loud noise. Stapedius is also already been, it's safe. Then loss of taste from hard palate, that's being carried by greater superficial petrosal nerve. So what will be the answer here? So because this motor component of facial nerve, which was reaching to the facial muscles, that will be lost. Since the impulses will not be carrying downwards. So there will be answer will be paralysis of this, facial muscles. This will be the answer, right? Okay, let's see the next question here. Now you see the side of lesion. I think the side of lesion is the same. A lesion here between the branching of the stapedial nerve and the branching of the chorda tympani nerve will also cause, what will also cause? Loss of light touch from the soft palate. Again, remember the greater superficial petrosal nerve is intact. So loss of taste from the soft palate, that also was being brought to the greater superficial petrosal nerve. So that is intact. Loss of taste of anterior 2/3 of the tongue, that was being brought in through this chorda tympani. Then loss of temperature from the soft palate. Again, everything from the soft palate, hard palate was being brought to the greater superficial petrosal nerve. So what will not be traveling is the loss of taste from the anterior 2/3 of the tongue. Got it now? So this is the area which will, you will not receive impulses through this point. Portion number 3. Now the site of lesion has been changed here. It's at the level, the one effect of lesion here at the stylomastoid foramen will be, right? At the emergence, at the point of emergence of facial nerve outside the skull. That means after giving out this chorda tympani branch. Now what it will lead to? Loss of light touch from the soft palate. Again, you are sure that is through this greater superficial petrosal nerve, so it is intact. Loss of salivation of oral cavity. Remember, salivation from oral cavity was through this chorda tympani. Then increase and oral cavity, the actually secretions from oral cavity will be again be controlled through this greater palatine nerves, through this greater superficial petrosal nerve. Then increased sensitivity of loud noise will be controlled through this nerve to stapedius. Then partial loss of sensations of external acoustic meatus. So loss of sensations from external acoustic meatus was just brought in by this posterior auricular nerve. So that will be restricted, right? So the answer will be here that this impulses from this portion will not reach to the nucleus, that is the spinal nucleus of trigeminal. Got it? Okay. Question number 4. A lesion here, you can see now this lesion here is between the branching of the greater superficial petrosal nerve and the branching of the stapedial nerve here above, right? So what will be spared? Anterior two-thirds of the tongue, taste from the anterior two-thirds of the tongue will be spared? No, because the impulses wouldn't now travel beyond to this. Taste from hard palate, yes, that can be carried to the greater superficial petrosal nerve. Salivation in oral cavity, no, that was being controlled through the chorda tympani, so that will not be controlled. Ipsilateral expression, yes, that will be lost because these fibers, the motor fibers from the facial muscles of facial expression, they also are being blocked. So they've asked is what will be spared? So taste of hard palate will be spared, right? Because this is the only nerve which is this is the only branch of facial nerve which is left after lesion at this point. Okay, that's greater superficial petrosal nerve. Question number 5, again the site of lesion is same. The lesion here between the branching of greater superficial petrosal nerve and the branching of stapedial nerve will also spare here between stapedius nerve to stapedius and greater superficial petrosal nerve. What it will spare? Light touch from the soft palate, yes, it will be spared because it is being brought in through the greater superficial petrosal nerve. Ability to smile, no, because zygomatic nerve has been, this zygomatic branch of the facial nerve that is through this main terminal division of the facial nerve, that will be blocked. Taste from the anterior two-thirds of the tongue that was being carried to the chorda tympani, that also is lost. Then protection of the inner ear from the loud noises, right? So what prevents hyperacusis is nerve to stapedius, that also the sensations will not be carried down now to this muscle stapedius. So this will spare light touch from the soft palate. Okay. So it's done from my side. I will now share the screen. I will ask Dr. Pranshu to continue the session. Thank you, Nextillo.
Thank you, Dr. Mohsin. I think this was a wonderful session. You have already shared majority of the things about facial nerve, its anatomy, and even the clinical importance.
Thank you, Dr. Pranshu.
Now I'll ask them to make me the host so that I can continue with the presentation.
Sure.
I think the video is visible, the slides. Yeah, I'm visible now, I think. I'll just share the screen. Okay. So as sir has already covered majority of the topic and the most important things about the facial nerve, let's see the nerve from a surgeon's point of view. First of all, we are talking about the facial nerve, the seventh cranial nerve. So, sir has taken up 99.99% of the topic and sir has explained it beautifully. So, if you want to save this session, it will be great for you just for a quick revision through the time. For now, I'll give it a different approach. So, from starting, when the nerve is coming out of the CP angle, when the nerve is coming out, it comes out before coming out, it is as a single nerve. It is as a single nerve. Means the motor root of facial and the sensory division, they are intermingled inside. But once they come out as two separate ones, to which sir had clearly documented motor root of facial and the nervous intermedius. Now, a good thing and a strange thing, but a good thing to remember, this nerve, both the nerves, enter the internal acoustic meatus as two, and approximately 3 to 5 mm after entering into the internal acoustic meatus, they again join back to form the single facial nerve. So it starts off as one inside of the brain, it comes out as two and then again becomes one. It becomes one where approximately 3 to 5 mm from the opening of internal acoustic meatus. So this is one thing. So where is the union of motor root of facial and nervous intermedius or nerve of Risberg taking place? Approximately 3 to 5 mm from the internal acoustic meatus. Another thing, the exact place from where the nerve comes out, we call it as root entry exit zone. Root entry exit zone. Now, why is this important or what is its significance? See, the nerve which is there inside the brain has myelin around it. This myelin is produced by oligodendrocytes. Now, the nerve which is outside the brain also has myelin around it, but this myelin is produced by Schwann cells. So, the zone where there is the transition of myelin of central nervous system to transition of myelin of peripheral nervous system, the exact name which they give to it, it is the Redlich Obersteiner zone. Redlich Obersteiner zone, which is or can be seen at the root entry or root exit zone, also known as res zone, root entry exit zone. Now again, why this is important? Because sometimes there are vascular loops which can compress the nerve, and these are mostly present near the root entry exit zone. And once you know the exact details of the root entry exit zones of all the nerves, it becomes very easy for a surgeon to continue the surgery knowing where to look for the vascular loops. So this was just an addition. Okay, the course of the nerve sir has already explained it beautifully, but still I'll just quickly recap in ENT sort of a way which is related to ENT. So nerve enters the internal acoustic meatus. They become one after some time. It continues, takes a turn at the first genu, becomes horizontal, takes a turn, becomes vertical, comes out of the stylomastoid foramen. Now there are a few things. First of all, the parts. We divide parts as intracranial, the intracranial part of facial nerve, then the intratemporal part, intratemporal, then extratemporal. Now the intracranial part is clear from the uh, your emerging after emerging from the brain stem till entering the internal acoustic meatus. It is the intracranial part. Once it enters the internal acoustic meatus till exiting from the stylomastoid foramen, this whole part we term as the intratemporal part. And then once it's out, it is the extratemporal. So the one which is of importance to us is the intratemporal part. Intratemporal. Intratemporal part can be divided into meatal, because once the nerve has entered the meatus, it is known as the meatal part. Then just in front of the labyrinth, when it crosses the labyrinth, when it is crossing the labyrinth, this smaller narrow part we call as the labyrinthine part. Then it takes a turn, becomes horizontal, lies in the middle ear cavity. This part we call as the tympanic part. Then it becomes vertical, goes behind the pyramid. This is the pyramid, goes straight down. This is called as the mastoid part. Tympanic part is also called as the horizontal part. Mastoid part is also called as the vertical part. Then it exits from the stylomastoid foramen. Okay, so here we'll not go into too much theoretical detail. I'll just stick to few basic things. Identifying landmarks, identifying landmarks for facial nerve. If you consider internal acoustic meatus, where there is a horizontal septae, there is Bill's bar, this is anterior, this is posterior, anterior, posterior. The only thing which is of importance to us, where does this nerve lie? Anterior superiorly, anterior inferiorly, posterior inferiorly, or posterior superiorly? The answer is anterior superiorly. Facial nerve lies in the anterior superior quadrant here. This is one. So if a surgeon is drilling and he has reached this place, how and where to find the facial nerve? In the anterior superior quadrant. That is one. Two, labyrinthine part of facial nerve is closely related to the ampulated end of superior semicircular canal. So let me make it for you so that you can understand it better. Superior canal, ampulated end. This is the crus commune, common opening. This is the posterior canal. Then we have lateral semicircular canal. So the nerve which is coming from there lies in close proximity with the ampulated end over here. This is the ampulated end. Superior semicircular canal. So this is the labyrinthine part. Labyrinthine part of facial nerve. So this we can mark as an MCQ also. The labyrinthine part of facial nerve lies in relation to, the options can be superior semicircular canal, non-ambulatory end, superior semicircular canal, ambulatory end, posterior semicircular canal, ambulatory end, lateral semicircular canal, ambulatory end. The answer will be superior semicircular canal, ambulatory end. Now the facial nerve, sir has already told us that at the first genu there is a ganglion which is the geniculate ganglion, from where we get the nerve, first nerve, branch 2, which goes and forms the greater superficial petrosal nerve. From this, then the nerve becomes horizontal, comes back. This horizontal nerve lies above the promontory in a bony cage or bony canal, which we call as the horizontal facial canal. And this whole thing lies on the medial wall of middle ear. Now this nerve will become vertical, and this will lie in close proximity to curve of the lateral semicircular canal. Curve of the lateral semicircular canal. So labyrinthine part was in close proximity to ambulatory end of superior semicircular canal, whereas I'll write it here, labyrinthine, whereas the tympanic or the horizontal part lies in close proximity to the curve of the lateral semicircular canal. Now the nerve which had taken a turn become horizontal becomes vertical, lies behind the pyramid. From the pyramid is the attachment of stapedius muscle. Now here, this gives a nerve called the nerve to stapedius. If you look closely again, here lies the ambulatory end of posterior semicircular canal. So the mastoid part or the vertical part is in close proximity to posterior semicircular canal ambulatory end. So I can complete this over here. Posterior semicircular canal ambulatory end is in close proximity to mastoid or vertical part of fission nerve, tympanic or horizontal for curve of lateral semicircular canal, labyrinthine part is in close proximity to ambulatory end of superior semicircular canal. So whenever we are drilling, we have to be careful for here for the ambulatory end of superior semicircular canal, here for the ambulatory end of posterior semicircular canal, and here for the bulge of lateral semicircular canal. So this is how the semicircular canals are related to the facial nerve. Okay. Now, uh, in detail facial nerve anatomy with respect to drilling or with respect to the surgery, we'll be covering in a different topic because this is a short class about integrated learning. I'll take up the most important topic which was due and is supposed to be taken today, that is Bell's palsy. And we'll not go into the details of Bell's palsy, but something which will help you clinically as well as for your questions. First and foremost thing which is important to remember is Bell's palsy is idiopathic lower motor neuron palsy. Always remember that it is lower motor neuron palsy. The lower motor neuron is involved and not upper motor. Now, how to correlate or find this clinically? First, try to see it this way. This is the face. The upper half and the lower half. This is upper half, this is lower half. I'm making it easy for you to understand just for concepts. Okay, how to remember this? This is right side, this is left side. I'll make it here also right side, left side. A right side nerve or upper motor neuron this is for upper face, here also and here also upper. This is for lower face, this is for lower face. Now if you see, right sided upper motor neuron will help in innervating right sided lower, right sided upper, but will also give a branch to left sided upper, but not the lower one. So there is innervation of the contralateral side of upper face, only upper face, not the lower face. Now, if there is a lesion, suppose there is a lesion. If there is a lesion here, that is upper motor neuron lesion, or there is a lesion here, left side upper motor neuron lesion, no impulse will go from here to upper or to lower. Hence, the functions of left side muscles of upper face and lower face should be gone. It should be paralyzed. But there is cross innervation coming from the right side, which is still active, and it is still innervating what? The upper part of the facial expressions, or the upper part of the facial nerve, which is supplying the upper facial muscles. So because of this, even in case of upper motor neuron lesion, the forehead muscles will have supply. This will be due to the cross innervation from the opposite side. So these wrinkles or this frowning will still be present in case of upper motor neuron lesion. Whereas if there is a lesion which is lower motor neuron lesion, if the lesion occurs at this level, so all the three innervations will be gone. Even the innervation from the opposite side will be lost. Even this will be lost. Even this will be lost. Everything will be lost. And there'll be a complete palsy of upper lower both. And this lower motor neuron lesion is what we are calling as Bell's palsy. So in case of Bell's palsy, this frowning of one side will be lost. It should not be present of the affected side. So whenever you get a patient, the things to be examined, which happens in day-to-day life also, we get many patients who are wrongly diagnosed as Bell's sometimes, because what people usually notice is deviation of the face. If suppose palsy is of right side means these muscles are paralyzed. So the action of this muscle will pull the mouth towards this side. There will be a deviation of mouth towards left. And then the eye closure of the right side won't be there. It will be open. But then we have to we have to ask the patient to look up so that there can be frowning, and we have to make sure that this side there is no frowning, whereas there is frowning on this side. This is what we'll call or label as right-sided lower motor neuron palsy. But if frowning can be seen on this side, it means this palsy is not of lower motor, this is of upper motor neuron. And if the frowning is present, it cannot or can never be Bell's palsy. Bell's palsy has to be lower motor neuron lesion. Now, what if there is frowning present? What you need to do after that for upper motor neuron lesion? If there's upper motor neuron lesion, you have to check for other things like gag reflex, like corneal reflex, to check for other adjacent cranial nerves, whether there's a tumor or there's a mass which is compressing the upper motor neurons. And if it is doing so, it will be compressing the nerves which are present just adjacent to the facial nerve, nerve number 8, nerve number 6, nerve number 9. So we have to check for that. Okay. Now, if it is Bell's palsy, it's always advisable to start the patient within 24 hours on steroids. That is the treatment of choice, oral steroids. If not contraindicated, best is prednisolone or methylprednisolone. Preferred dose which we give is tablet Visolone, 60 milligrams first 3 or 4 days. How to give this 60 milligrams? Divided into 3 doses, 20 20 20 TDS for first 4 days. Then next 4 days you can taper it off to 20 20 and 0. Morning, afternoon, night. So morning, afternoon, night. Then after 4 days, for the last 4 days, you can taper it to 20 0 0. And then you can just put it off. We have to taper it off. Now, why are we giving it in such a fashion that we are preferring the morning dose? We are preferring the morning dose. I have given it like XXX, then tried to reduce the last dose, and then tried to keep only the morning dose. Why? Anyone from the audience? If there's anyone who can answer this, we'll definitely share his name and credentials over the Instagram page, because this is a good question. So the answer to this I'll explain in the next class whenever possible, but I'll be waiting for someone to answer it. Okay. Then some people prefer antiviral, However, there are articles which say that antivirals these days, like acyclovir, may or may not be of help. Then there is facial physiotherapy, which is very, very, very important. Now, as we had discussed that if it is not lower motor neuron lesion and not Bell's palsy, and we suspect upper motor neuron lesion, we should look and check for other adjacent cranial nerve tests like the gag reflex. We should look for the corneal reflex. Now, once you have looked for all these and you find some issue with that, if there is the reflex is not present or is abnormal, we should go for imaging of the brain. Then MRI becomes an important step in the management for upper motor neuron lesions. Okay, so before ending the facial nerve topic, I have a very important question for all of you. Facial nerve palsy, usually there is, people are unable to close their eye. The eye closure is not there. That leads to dryness in the eye. But if there is a question, facial nerve palsy or Bell's palsy can present as all of the above or all of the below, except, and your options are dryness of eye, unable to close eye, deviation of mouth, then watering of eye, none of the above. Usually people will think that it is none of the above. That's what mostly people feel, but watering of eye is a doubt in everyone's mind. So my question is, what is the correct answer over here? Can a patient of facial nerve palsy or Bell's palsy present with watering of eye? Should the answer be none of the above, or should the answer be watering of eye? Like except watering of eye. So watering of eye can never happen in facial nerve palsy, or it can also happen and a patient can present with watering of eye. Which is the correct answer? Here the correct answer is none of the above. Means that watering can occur. Means watering can occur. How and why? See, the tears are still being produced, but not tears are not being taken to the punctum. Why? Because one of the main functions of orbicularis oculi is to push the tears towards the punctum. So when they are not pushed towards the punctum, they do not reach the lacrimal sac. And when this does not happen, watering occurs. Not in all patients, but yes, some cases watering can also occur in cases of facial nerve palsy. Well, for today, this is it. We'll be going into the depths of facial nerve once we take up the lecture of the facial nerve. Now, I would like to hand it over to the host. If there is any question from the audience for Dr. Mohsin or myself, would like to take up the questions. So that's it from our side. Thank you, Dr. Mohsin, and thanks to Dr. Sunil for giving us this opportunity, and the Nextillo team. I'll say I'll be waiting for the answers of the questions which we have asked. And before the next class, let's see how many of you get the answer to that question. Thank you. This is it for today.